right, good morning, everybody. Thank you for joining us for our fifth virtual community opioid symposium. This will be 1 hour, 8:30 to 9:30. Dr. James Hussey and Dr. Arwen Podesta will be presenting on addressing and reducing the stigma of addictions across all professions. This is a free educational event brought to you by the Louisiana Department of Health, Office of Behavioral Health, Acadian Area Human Service District, and the Women's Foundation. This session will be accredited for 1 hour for social workers, general CEUs, LPC, ADRA, psychologists CEUs, and AMA PRA Category 1 credits. Full participation is required to receive credit and will be monitored throughout the session. After the event, you'll receive an email from the Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Dr. James Hussey has no financial disclosures. Dr. Arwen Podesta disclosed a relationship with Orexa and Pear Therapeutics. These financial relationships do not impact the presentation. And none of the members of the symposium's planning committee have any financial disclosures. Dr. James Hussey is a board-certified psychologist who is currently serving as medical director for the Louisiana Department of Health, Office of Behavioral Health. Since February 2018, Dr. Hussey has been serving as the chairman of the Louisiana Drug Policy Board's Advisory Council for Heroin and Opioid Prevention Education. Dr. Hussey has served as the assistant secretary and medical director for the Office of Behavioral Health and former behavioral health medical director for Louisiana Medicaid. Dr. Arwen Podesta is a board-certified adult psychiatrist with subspecializations in addiction medicine, forensic psychiatry, and integrative medicine. Since opening Podesta Psychiatry in 2012, Dr. Podesta has been voted into the ranks of New Orleans Magazine's top doctors on an annual basis. The Podesta Psychiatry team includes some of the best treatment providers in the Gulf Coast, and Podesta Psychiatry continues to evolve towards the multidisciplinary collaborative model that embodies Dr. Podesta's wellness model for whole health. Without further ado, I give you our speakers, Dr. James Hussey and Dr. Arwen Podesta.
Great, thank you. Thank you, Ashley, I appreciate it. Dr. Podesta, thank you for doing this with me. I appreciate it. We're gonna do a little tag teaming today. So I'm gonna start off and do a couple of slides, and then Dr. Podesta will jump in, and as I go through my content, she may well have some comments to make during that presentation. So we welcome those, and let's go ahead and get started. Give you a little bit of an overview. What we're talking about here, we're going to define stigma and demonstrate its impact on those with substance use disorder first and foremost. And then we're going to really try to weave in stigma from a provider's perspective, have some time hopefully for some discussion, questions from the audience, and then some recommendations on actually how you might address stigma more in what you do every day and how you can decrease the impact that stigma has on those with substance use disorders. So I thought, I was going through this, putting this information together originally, I came across this quote, which I thought was great because I think there's a lot of parallels here. This is from Martin Luther King Jr. People fail to get along because they fear each other. They fear each other because they don't know each other. They don't know each other because they have not communicated with each other. And so we'll find it's very important how we communicate with one another. It's very important to really know each other and try to understand what the other person is going through. That'll do a lot to move us towards decreasing the negative impacts of stigma. Now I'll kick it over to Dr. Podesta for an example.
Thank you. I love that MLK quote, and so pertinent in what the world is going through, I think. And I think one of the confusing things is we have a lot of I have this slide titled Shame and Stigma, or Shame/Stigma. So shame is different than stigma and it's different than guilt, but it's all based in fear. And so at the bottom, think about what guilt is. It's about an action. And so if you have, maybe you've heard someone suggest that you should be guilty or you should be ashamed of yourself. And so think what that was when you heard that. And usually the person saying that is usually thinking that it's going to modify behavior, it's going to improve behavior, or at least it's getting their feelings off of their chest. So depending on who, if it's you receiving the words, depending on your biology, your self-esteem, your stress at the time, you may have resilience that will compel your brain not to internalize the shame, or you may internalize the shame. And so that where shame and stigma cross is that there's external shame known as stigma awareness, involves like fear of criticism, fear of social rejection, and we'll get into how that affects the biology of the brain later today. But shaming's not necessarily what the act of shaming is going to affect society, is going to affect your clientele, is going to affect your patient. And so when we can make sure that our shame words are limited and our stigma, because stigma is what is within our mind and within our thoughts. So when we can reduce stigma, reduce shaming patients, then we can improve treatment. So I'm going to talk to you a little bit about one of my patients. She's a 60-year-old law clerk. She's married and has 3 adult children. I started seeing her about 5.5 years ago, and she was on opioid pain pills. First, she had a surgery when she was in her late 40s, and then she kept on taking the pain pills because she was deemed to have chronic pain. She tried to stop on her own with no success. And then after about 5.5 years ago, you may remember some MDs that might have been not practicing very well, and they lost their license. And she was one of those that suffered because she was a patient, and she wasn't able to get pain pills again. And now she's an upstanding citizen. She's, in the community. She works, but she wanted to get discreet treatment. So she ended up coming to a center that I worked at the time, and she wanted to not tell anybody that she was getting treatment for opioid pill addiction because she was really finding herself with addiction. She had this massive fear of humiliation. And so we're going to go through thinking of shame. She is internalizing shame so deeply that she didn't want to tell anyone, not even her children. The only person that knew anything about this was her husband, and he was aligned with her treatment. Anyway, so I'm going to talk about her later. I just want you to get a picture of, we're not necessarily talking about someone that is, heroin, crack cocaine on the street, no one that has any criminal justice charges. This is a real patient description that we see so frequently. And so when someone has shame like she has, fear of humiliation, when they're asking for discreet treatment, I find it's really challenging for me as a provider to be able to do a lot of motivational interviewing and spend a lot of time trying to help move them to the next level, which is about honesty. Because low dopamine is susceptible to shame. And you always hear me talk, if you've heard me talk, you hear me talk about the low dopamine and addiction. Low dopamine is susceptible to shame. Shame can cause low dopamine. And again, we'll get into the neurobio in a while about how that goes back and forth. So we'll talk about LD in a while, and you'll hear a little bit more, but I want you to either think about, as we're going through all of this, think about her as a possible example of what she's going through when Dr. Hussey's presenting some of the shame information, or think about something that you've experienced in your own past. A lot of people have been told you should be ashamed of yourself, and what did that feel like, and how did that not help you feel your best self? All right, Dr. Hussey.
Thank you. A couple of more quotes to kind of continue to set the stage just a little bit. And these quotes come from Dr. Patricia Harris, who's the current lead of the AMA, the American Medical Association's Opioid Task Force. And she wrote these back when she was the interim president of that organization. And she stated, we must all confront the intangible and often devastating effects of stigma. The key to recovery is support and compassion. Patients in pain and patients with a substance use disorder need comprehensive treatment, not judgment. So,
I'm sorry. I might add, as we're thinking about these words, this is true in those with mental illness as well. And mental illness has been very stigmatized and compartmentalized, just as substance use has over the years. So as we're thinking about, applying all of this, I encourage folks to apply it to those with mental illness in the same way.
Absolutely. Thank you. Now, there's an organization called Shatterproof, which the Office of Behavioral Health has partnered with to try to bring some more transparency and information to those seeking substance use disorder treatment. And I found a few items on their website and in their literature I thought were very helpful. And it talks about the idea that addiction is a public health epidemic, and it notes that drug overdose is the #1 cause of accidental deaths in America, recently surpassing car crashes, and also stating that nearly 9 out of 10 people who need help never receive treatment. Stigma directly fuels this problem, this crisis, in 3 major ways, and here they are. #1, stigma isolates people. Given that it's the #1 most socially disapproved of medical condition that exists, public perceptions of users as bad, reckless, irresponsible, means that those with substance use disorders are much less likely to come forward and seek help. And I think Dr. Podesta's earlier example kind of started to hint at that a little bit. Someone with a substance use disorder is more likely to withdraw from a family, from friends, to try to hide their addiction for fear of humiliation or shame. This isolation and loneliness can ripple out to the family, to friends, and the shame and stigma the families feel may prevent them from seeking support for themselves, because we know that substance use and mental illness can have a negative impact and a difficult impact on families themselves. Sometimes they need some help and they're afraid to go out for fear of humiliation or shame. The second item here that Shatterproof offers is that stigma discourages people from seeking treatment. So when a person with substance use disorder has internalized that negative stigma of the disease, it directly damages that person's chances of recovery. So it's, talking about evidence-based treatment options like medications, stigmatizing ways, claiming it's just replacing one drug with another is not real recovery. Fuels harmful stigma. And I can tell you, I'm going to pause after this, but I've heard this so many times when I've spoken about substance use disorder. Methadone, buprenorphine, MAT, isn't this just replacing one drug with another? And I would invite the audience members to inventory yourselves. How many out there have high blood pressure, diabetes, obesity, other chronic medical conditions? And we don't hear when we go to our physicians for this is that, no, I'm not going to give you your high blood pressure medication or your metformin or your insulin because, I'm just enabling. I'm kind of substituting a drug for what you should be doing differently with your lifestyle and with your diet or your exercise. We don't hear that, but we do hear it with this set of disorders. Dr. Podesta?
Well, and so when we think about other addictions that are less stigmatized, smoking was sexy 50 years ago, and we're dealing with the fallout of that, but people still smoke, and the judgment and the stigma is not nearly as tough as it is. Think of people around you, family or friends that have smoked and tried to quit on their own 5 to 10 times. That's the average. And then when we add therapy, it goes up highly. They have a much higher likelihood of quitting smoking. But you know what else works really well? In conjunction with therapy or just accountability, a huge component is adding medication-assisted treatment, which is really working at the receptors, the nicotine receptors, just like cigarettes do, but by kind of cushioning it. And there's 2 medicines that people know about, bupropion or Zyban and Wellbutrin are the brand names, or Chantix. And those, many people have taken those without feeling ashamed of needing a crutch or of just replacing with one drug for another, because Chantix works at the nicotine receptors the exact way that buprenorphine works at the opiate receptors. And so when I have given this talk, and I had a judge that was right next to me talking about how buprenorphine was just replacing one drug for another, and he's sitting here chewing on a cigar. And so we were talking about like how he was getting that nicotine still right in front of us. And, it really hits home. If we can think about a medical model, diabetes is a great medical model where if we just changed lifestyle and we just changed everything about the person's existence, then perhaps we would have recovery from diabetes, but not in everybody because there's a biological underpinning. But thinking about nicotine and the nicotine receptor and how the medication-assisted treatment works, and it works really well, and it is a far cry from replacing one drug for another, because it actually saves lives and helps people stay steady and smooth, as opposed to getting that up and down, which is what drug ingestion does.
Thanks. The third thing that Shatterproof offers is that stigma directly fuels the crisis by impacting how health professionals treat patients. Negative perceptions of people with substance use disorders are all too common among healthcare professionals, and evidence has shown that this negative attitude among medical professionals may directly contribute to worse care. I'm going to cover more of that a little bit later, but and we'll also, I think, cover this study. The study was done, I think, in 2009, but I think the results were probably published in 2010, so you'll see this in a few minutes. But in this study, it was kind of a survey where researchers asked a group of trained mental health and addiction specialists and some others to read one of two written passages. So I'm setting this up, really a slide that's going to come a little later, so look for it. But one group read a passage that referred to the individual as a substance abuser, and the other group read a second passage that referred to the same person as having a substance use disorder. Those were the only differences, is how they were referred to, either substance abuser or one having a substance use disorder. And you'll see later that the results show that even the small difference in wording has a big and measurable, tangible impact. Terms like the war on drugs have been ineffective, costly, damaging. It kind of puts a punitive spin on things, and it's ineffective. Word choice is very important and can be very damaging. In order to provide better access to evidence-based medical treatment that anyone suffering from disease deserves, we need to really change the way we talk about people with substance use disorders. So what is stigma? Let's talk about it. I think we all have our own understanding of it, but I don't want to have any assumptions here. One definition is it's an attribute or behavior or a condition that's socially discrediting. And when I've seen stigma written about and grouped in different ways, I thought this was an interesting way to look at it. Public stigma versus self-stigma. And you'll see as you look at this slide that each one has with it a stereotype, a prejudice, and a discrimination, and one leads to the other. So, for example, with public stigma, the stereotype is a negative belief about a group. In this case, that those who use substances are dangerous, incompetent, they have character weaknesses, and that can lead to a prejudice. And a prejudice is an agreement with that belief or that negative emotional reaction. So they can become angry or fearful of that group of people based on that stereotype. Then that stereotype and that prejudice then leads to discrimination. And that's a behavior response to prejudice. So people avoid, exclude, withhold employment, withhold housing, sometimes withhold treatment. So that can be the impact of public stigma, and the same sort of chain happens with self-stigma. But as Dr. Podesta mentioned earlier, this is when the person internalizes that stigma, that stereotype, that prejudice. And so in this case, the stereotype is internalized. It's a negative belief about the self. The person buys into the idea that maybe they have a character weakness, they're not worthy, they're incompetent. That leads to kind of a self-prejudice, an agreement with that belief, and an internal negative emotional reaction about the self, a self-prejudice. So they feel bad, low self-esteem, low self-efficacy. Then that stereotype and prejudice then leads to really a form of self-discrimination. It's a behavior response to that prejudice. And the person fails to pursue work or housing, or maybe even fails to pursue treatment.
And often fails to not just pursue regular improvements, but if they're parents, they fail to care for their children. And this is even true across cultures. If they start failing to care for themselves, and that's where we see some of the downward regulation of some of the neurotransmitters, and therefore they become even more susceptible to relapse if they haven't relapsed, or to continued use and more isolation.
So I've included a couple of examples. I'm not going to go into these in as much detail as I originally thought, but in these self-stigma examples, this is a quote from an individual who identifies himself as Graham, stating that he struggles with people offering him help, that he still thinks he's not worthy. He feels that everyone has been offering help, and he just says no. It's all right. I'll get a taxi. I'll carry it. Whatever. You know, I'm the guy who can do it myself. I don't need your help. In other words, I'm not weak, right? I have strength, and so he almost denies help based on a fear that he might be projecting that he's not competent to do this. And he kind of feels, though, on the other hand, maybe he's not worthy of anyone's help. Another example is a self-sabotage example. And Tim here says, I know a lot about these drugs, how to get off of them. I know the treatments. Sometimes I know as much as the doctors. Don't get me wrong. People think sometimes that addicts, the term he uses here, are stupid, dumb idiots. He's met a lot of really intelligent addicts, as he calls them. And so he doesn't think that at all. He knows he's got potential as well, but there's just something in him that says, yeah, and he keeps sabotaging himself. So this idea of self-sabotage and wondering whether or not they can hold it together and do something, because if they fail again, because they see themselves as failure, they'll just be even more ashamed, so maybe they don't even try. And so I thought those were a couple of good examples of self-stigma and self-sabotage.
I was,
stigma.
yeah, I was on a call recently with someone who is a director and marketer for addiction recovery centers in another state, and she herself divulged that she has been identified as someone with addiction, and she kept using the word addict for herself. She said addicts are addicts, and she said we like to call ourselves addicts because then we know that we're not better than that. And so I tried to have this, you know, it was on a business call, so I wasn't really able to get deep into the conversation with her about stigma and the words and how the words really matter. But I felt like when she told me that, I felt a sinking feeling. I felt less respect and interest in having a business relationship with her because she was identifying her as someone that she wanted to self-sabotage. And she identified that the word addicts, the way she used it, was with the intent of keeping herself down. And she said humble, but she also said, you know, we're not better than this. And so it sounded diselevating, you know, and it was really troubling. And I think and from within, we need to be able to think about that and think about how we ourselves as treaters, but also our friends that may have different struggles might be using words.
A couple of more quick examples of self-stigma. And this is a case, Isabel here, who looks at her arms and thinks to herself, who wants to go out with this? Heroin doesn't leave those kind of marks itself, but it affects him. It affects her, and she feels like she can't wear short tops, short sleeves. I can't be a normal person anymore. And I've seen this myself in the limited number of individuals that I've talked to in my own practice who have used heroin or IV drugs, that this is a real big limit. This is a big deal for them, that they can't socialize, they feel ashamed, they don't want to go out, they can't share personal experiences. You know, their friend groups are different from the past. So very, very, very limiting, very difficult. Another one here, Martina, the quote here, I just want to be able to do what everyone else does. And unfortunately, I got these marks from using. If I was doing customer service, for example, a doctor would know that I used to use, and I don't know if that would help me get a job. I have to wear long sleeves every day. I have to make myself up and feel presentable to overcome that.
So I think about this example a lot, and I have, and I think about it not just with heroin or with skin issues from using, but also with cutting. So people that have been cutting, they have to wear these you know large long sleeve shirts, and in the South that's awful in the summer, you know. And so think about the shame that goes with. Think about yourself if you were to put on, in the middle of the summer, if you were to put on like a long-sleeved, hooded, dark doesn't have to be dark, but something, think about what that feels like. And then the posture that comes with that, and the posture actually self-reflects onto the neurobiology and down regulates the positive neurotransmitters. So the more we slump, that's how we feel when we feel shame. So think about what that feels like and what Martina and Isabel are going through here. And it just keeps them more isolated, which again, more isolation, less connection, more biological and social reasons to find more relapse and use.
Anyone who may have seen me or others in the Office of Behavioral Health in a tour we did, a public forum tour about a year and a half or two ago, might remember Dr. Josh Sharfstein, who made the tour with us. We did a lot of public feedback, and he came in from Stanford. He is quoted here along with Dr. Olson on 4 factors that contribute to stigma on opioid use disorders. Number 1, the understanding of opioid use disorder as a medical illness is still overshadowed by its misconception as a moral weakness or willful choice. And I think we talked about that a little bit before. We'll talk about it again in some of the surveys, that this really is a medical illness, not unlike diabetes or high blood pressure or other chronic medical diseases. But yet we think about them differently, and that affects people's access to treatment and the outcomes. Number 2, the separation of opioid use disorder treatment has meant that clinicians overlook other health issues. And I can tell you, we in the Office of Behavioral Health, we oversee, through Tracy Perry, our State Opioid Treatment Authority, we oversee the 10 methadone clinics across the state. And we get the reports, unfortunately, pretty much every other week of somebody dying. And these people aren't dying from overdoses, the reports I get. They're dying at young ages, 37, I saw one last week, 39, 53, of chronic medical conditions that others don't die from because they're seeking help and treatment. So I think there are a lot of ways to look at this one, but part of it is the clinicians overlook other health issues. Sometimes the patients themselves kind of refrain from treatment, fear of discovery of their other substance use problems. But this really is separation and not looking at the substance use clinics themselves. The opioid treatment programs don't necessarily do the screening they could do for medical problems. And so that's something else we'll be working on. Number 3, loaded language furthers stigma associated with the condition. Number 4, the criminal justice system's unwillingness to yield to medical judgment in the treatment of opioid use disorders. And we know there are a lot of people in the Department of Corrections who have substance use disorders. They're not getting treatment for the most part in most of those settings. And then when it comes time to transition out, they don't have the tools they need to transition safely in a healthy way, get hooked up with treatment. And oftentimes those first 30, 60 days are really high risk times for those individuals to overdose because they'll go back into using and their body is not ready to tolerate the amount of the substances that they were taking, say, before they went in.
Yeah, and regarding criminal justice, without when someone's sitting in jail and not attending to their addiction, we kind of like to think that their addict part of their brain is just doing push-ups for the second that they can get out and find the drug. And so that first 3 days is critical in getting people help when they leave criminal justice, and then of course the first 30 and 62. As far as clinicians and primary care, this is true in psychiatry in general. Psychiatry and addiction have some of the same treatment problems because we are siloed oftentimes without the rest of the medical community. So my recommendation wherever I work, my requirement wherever I work as medical director or as consultant, is that on the front end, when someone comes in for addiction treatment, that one of the questions asked is, do they have a primary care provider? And if they do not, that if we're in a position to be able to refer, that's really helpful. If not, teaching them how to find a primary care provider, because one of the problems is, like Dr. Hussey was saying, that a lot of people don't interface with the medical community because they have shame, they have fear, they are avoidant. And So they might have more advanced disease states, and then they're at more risk of dying of things that are more that are really treatable. I mean, when we have hepatitis C treatment available, we just have to connect the individual to the treatment facility. So you can help them with getting their medical provider or I'm sorry, you can help refer them, or you can help them help themselves by calling their insurance.
I found this next slide interesting, and note these are not concentric circles. I just kind of noticed this as I'm looking at the slide. They're concentric walls. I thought that was an interesting part of this figure here. In the middle of all these concentric walls is the self. And so we talked a little bit about self-stigma already, right? And how that can extend to the family, and how that can not only negatively impact the individual with the addiction, also have a negative impact on the family, their ability to seek help, their willingness to do it. Also the healthcare providers, and in a couple of surveys, a bunch of survey questions we're going to cover in just a few minutes, you're going to really see how stigma really affects healthcare providers' interest and willingness to provide treatment for those with substance use disorder, maybe even a failure to recognize how the healthcare provider, him or herself, is contributing to the use or misuse of opioids. Social stigma, we talked about a little bit, and we'll continue to talk about it, but the one here I also wanted to focus on is structural stigma. What is that? I really encountered that in a very clear way back in 2010 and 2011, when we were redesigning the mental health system for Medicaid recipients. We had things covered like inpatient psych hospitalization and outpatient therapy, things like this. But you know, it wasn't covered at all. Nothing in Medicaid covered substance use disorders, period. So prior to 2010 and 2011, there were no ASAM levels being paid for by Medicaid. So people with substance use disorders with Medicaid had no access to reimbursed treatment. And this, I can tell you, kind of being on the inside, was because, sure, there were some issues with some of the providers, as there is with all providers. I see problems with fraud and abuse and waste in all providers. But those with substance use, those providers, when they demonstrated some of that, the reaction was shut down the Medicaid reimbursement for all substance use services. So prior to 2011 or 2012, these services were not funded. So now they're funded, but that's just a real world, real-time example of how stigma can really affect the structural integrity of the healthcare system.
Yeah, and Dr. Hussey, you and I have had these conversations for years, trying to get more funding for more patients to be able to seek treatment, and it started with stigma and a lot of doctors saying I wouldn't touch someone with addiction with a 10-foot pole, or they used to say, get these addicts out of my ER. Those are some of the other memories that I have. But it's been a wildly successful improvement with your addition, and with also the ability to have funding for these services.
Yeah, and as a matter of fact, we just got methadone covered, started, I believe it was 2015. So, we were in the bottom rung of the methadone clinics around the country, both in terms of the number and availability, access to those, but also in the funding of methadone and related services in those clinics by Medicaid. So we finally got that going 2015 and 2016, I think. All right, so just as a repeat from Dr. Harris from the AMA, just 2 in 10 people who seek substance use disorder treatment have access at the time they want it. Combating stigma will go a long way towards changing that. Unfortunately, we still have a lot of people who think that people who have substance use disorders have character flaws, or that having addiction is a moral failing. It's a brain disorder, as Dr. Podesta is discussing. It results in chronic medical condition analogous with other diseases like type 2 diabetes and high blood pressure. So here's where we're going to start to see where this stigma can be kind of measured, if you will. and language matters. Referenced earlier a 2009 study. I think the report actually came out in 2010. It was a 35-item survey given to 314 people related to how they perceive or feel about two hypothetical people using drugs and alcohol. Now, keep in mind, conceptually, these are the same people. They're identical persons, but one was referred to as a substance abuser, and the other person as having a substance use disorder. Now, the people who were asked about this, half of them were from healthcare fields. There were some students, some about 29% from outside of healthcare. They were average about 31 years old, 81% white, 76% female, and 50% with a bachelor's degree or higher. So these are people who are well educated. So the person who was referred to as a substance abuser, as opposed to having a substance use disorder, that person, that substance abuser, the respondents felt was less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening, more likely to be blamed for their substance use difficulties, and less likely that their problem was a result of an innate dysfunction, a medical problem over which they had no control. They were more able to control their substance use without help. That was the feeling, that the substance abuser should be able to control it themselves. So this is just a tip of the iceberg. We're going to cover some interesting additional surveys in just a minute.
What I love about this is it gets into really understanding the difference between, I mean, even if you don't have a conscious understanding of what the word abuse actually connotes, it really does like link to people feeling like abuse is negative and abuse is a choice. And then, you know, struggling or having a substance use disorder, that sounds so medical, and it makes a big difference. And so I just love this because we have like, you know, this subconscious understanding, and this is where that innate bias happens, right? So if we use a word that connotes something and there's an innate bias to that connotation, then we should check ourselves to maybe not use the words that connote these things. And so abuse is just so negative. It's like, you know, child abuse and drug abuse, and it's a choice and it's a bad action. And so it really does play out in this study. I think this is a great study.
So the researchers, the persons who did the survey, Kelly Dow and Westeroff, felt there were a few implications of the survey. So for individuals and families seeking recovery, the words abuser and abuse can evoke an automatic negative thought about that individual with a substance-related problem. Less stigmatizing terms should be utilized, and the result should be, hopefully, individuals with these conditions may be more likely to seek help, stay in treatment, and achieve long-term remission. The implication of the survey for scientists, for physicians and others, researchers might help grow this important area of research. For example, conduct more surveys on other common terminology like addict, alcoholic, etc. Implications for policymakers: with less stigma surrounding alcohol and other drug use disorders, individuals with these conditions might be more likely to seek help. In a related sense, experts have used these types of studies in support of public health rather than criminal justice approach to addressing the societal harms related to substance use disorders. Finally, the implication for treatment professions and the treatment system: with less stigma surrounding alcohol and other drug use disorders, individuals with these conditions might be more likely to seek treatment, and more providers might be willing to provide that needed treatment.
Yeah, and with addiction, you know, we think back to HIV, and we compared this for a while, the stigma against HIV and how we had little money to treat it, and a lot of physicians were unwilling to treat it, and it's a complicated disease, and a lot of physicians felt they weren't reimbursed well enough to treat it. And so then with the Ryan White funding, that really opened the doors for medicine and for reimbursement for treatment, for therapy, and more social and community services, as well as medical providing. And I see that with how we're propelling forward by having more money, because I've seen many providers, I don't want to touch someone with addiction with a 10-foot pole, but now we have more understanding and more resources, and also more financial reimbursement because of some of the funding that came down.
Now, this next study I found fascinating, things I almost couldn't believe when I read it. So hopefully this will be shocking to you in the sense that maybe you haven't experienced this, but unfortunately we'll see the results of this. Stigma and Prescription Opioid Addiction and Treatment, a national survey. This was conducted, when was this? I think 2019, I believe it was published. And it's social stigma around opioid use disorder and medication-assisted treatment has impeded progress to reduce opioid abuse, addiction, overdose deaths in the U.S. And Dr. LeBeurve here says that understanding stigma beliefs and behaviors can help inform us to enhance our OUD, our opioid use disorder treatment and recovery. So think about this as we go through these slides. Real quick, here are the research questions, right? These aren't actually the survey questions, but this is what he was trying to address with the survey. He wanted to answer these types of questions. To what degree does the general public hold stigmatizing attitudes toward people with who have prescription opioid use, people with addictions to prescription opioids, who are being treated or have been treated for opioid addiction, and the healthcare professionals who provide treatment for them. Number two research question was how knowledgeable is the general public about opioids? And number three, does the public perceive that people who become addicted to prescription opioids have access to treatment? 4 and 5 here, does the public have concerns about being treated by healthcare providers who treat people with addictions to prescription opioids? Number 5, is the public willing to have naloxone in their home or carry it in case of an overdose emergency? So here's the things I just found amazing in perhaps a negative way. Responses to knowledge items about opioids. So how much does the public in those surveyed know about opioids? Here is a statement that was asked to the respondents. Prescription opioids and heroin have the same chemicals and can produce a similar high. Now, the answer to that is true, but when you look at the respondents, almost 30% didn't know, 9% thought it was false, so only about 62% of people felt that was true. So the next one, people addicted to prescription opioids experience severe withdrawal symptoms when they stop using the drug. Now, this is true, and now 84% thought that was true. Most people addicted to heroin first use prescription opioids. Now, that's a true statement. But when you look at the respondents, about 20% felt that was false. 34% didn't really know. So there's an area for more education. All primary care physicians have been trained to treat people addicted to opioids. And that's been false. I can tell you my own training, we had very little training in terms of how to treat any type of addiction. And so that's training that occurs after you get out of medical school, pretty much on your own, at least when I went through. So the actual answer is false. But 47% felt it was false, but about a quarter of people thought it was true, that they've been trained. It's not possible to overdose on opioids prescribed by a doctor, and of course that's false. 83% agree that was false. Most people who become addicted to prescription opioids switch to heroin because it's cheaper. That's false. However, about 37% felt it was true, and about 42% didn't know. These aren't the amazing responses yet. Wait till we get to the next slide. People who are addicted to opioids can get treatment no matter where they live. And of course, that's false. But 52%, 53% felt it was true. 20% didn't know. So there's still a lot of misperception about availability and access to treatment. The next slide, agreement with items of social stigma. And this is where it begins to get more interesting. This in the following slide. Addiction is a medical illness like diabetes, arthritis, and heart disease. And 13% strongly disagree with that statement. 17.7% disagreed with it. And then another 17% were neutral. So a large number of people aren't quite ready to accept the idea that addiction is like a medical illness. People who are addicted to prescription opioids should be able to stop using them on their own. And now looks like maybe about only 17, 18% of people fully agree with that statement. Some people lack the self-discipline to use prescription opioids without becoming addicted, and there were a large number of people, 45%, who agree, and another 20% or 19% who strongly agree with that they lack self-discipline. So you can see stigma at play here. People who have recovered from having opioid addiction still cannot be trusted. And look over here, 12% agree, 4.5% strongly agree with that. Another stigmatizing thought. Individuals who have become addicted to prescription opioids are to blame for the opioid epidemic, and you can see about 22% agree with that. Employers should be allowed to deny employment to a person addicted to prescription opioids. 33% almost agree, and then almost 17% strongly agree with that. Landlords should be allowed to deny housing to persons addicted to prescription opioids. And again, you can see maybe 33% of people agree or strongly agree with that. People addicted to prescription opioids are more dangerous than the general population. And you can see that about 26% agree, and another 10.5% strongly agree with that statement.
It's a very great study, but it really does bear out. So what I see when I'm out there providing care, and when I'm in different locations doing talks and meeting with people at conferences and such. So really it's true to form. It's a great study, really shows us a lot of interesting pieces.
Now, this is where I find it's really interesting, and this is the stuff that really surprised me. Attitudes towards MAT, that's medication-assisted treatment, and providers who treat people with opioid use disorder. So medication-assisted treatment substitutes one addiction for another. And you can see that over a third of people agree with that. And about 42% are neutral on it. Only less than a quarter disagree with that statement. Here's where it gets really interesting to me. I would feel uncomfortable seeing my doctor if I found out he or she treated people who are addicted to opioids. Look at this. 34% agreed with that statement. 36% were half and half. And only 30% disagreed with that statement. A doctor should be allowed to refuse or stop seeing people if they are addicted to prescription opioids. And you can see that well over 30% agree with that statement. Here's the one that really amazes me. I do not want to see a doctor if they treat people who are addicted to opioids. 33% of the people surveyed agree with that statement, and only 28% disagree with that statement.
Right. I find this so troubling and so true, and this is why we're doing this. So hopefully with some of our tools for undoing this, or even just having this conversation, can help us be the perpetuators of the next steps in the community.
So we're going to start bringing this around a little bit in terms of recommended next steps. These recommended steps came from the doctor and the team who did that survey we just reviewed. The public's knowledge about opioids varies and points to potential public education objectives. Number one, increasing the percentage of people who understand that most people with opioid addictions cannot get treatment where they live. There's a real need for more access to treatment. Number two, increasing the percentage of people who recognize that most people with an addiction to heroin first abuse prescription opioids. It has direct implications on the healthcare profession and how they manage pain, and frankly also how people manage their own pain and what they can do for their own health to set themselves up to be less vulnerable to pain and being prescribed these medications in the first place. Increasing the percentage of people who know that not all primary care physicians have been trained to treat people with opioid addiction. Number four, increasing the percentage of people who understand what medication-assisted treatment is, and that it is an effective treatment for opioid addiction. And I'm going to say this without naming names, but I was about a year and a half ago at a round table with, I'm going to say, the leaders in the country in the government for the opioid response effort. I had to explain to that person and the legislator that they were with what MAT was. They didn't know what it stood for. didn't know what medication-assisted treatment was, they were in charge of rolling with, with the recovery effort around this nationally. Increasing knowledge about benefits and the risks of personal access to naloxone is the fifth item here. So moving on to additional next steps, the responses to the items related to stigma suggest the need for increased efforts to reduce discrimination around employment, healthcare, housing towards people with an addiction or to prescription opioids, focus and shift attitudes of uncommitted people towards supporting treatment and other services for people with an addiction to prescription opioids. Number three, increase healthcare consumer acceptance of physicians, especially primary care physicians who treat patients with opioid addiction. These are the last three items that came out of that survey in terms of recommended next steps. Dr. Podesta?
Yeah, so here we have some language, and we've got 2 slides on this. So just take a look at this, things that we can take home today. We should say certain things, probably not say other things. So the purple or red on the right is what not to say. Addict, junkie, druggie, ex-addict. We have some good language. Person living in recovery, persons with a substance use disorder, living with an addiction. Not say suffering or battling an addiction. I find myself saying struggling with frequently, and I want to undo that as well. Person arrested for drug diversion instead of drug offender. I work in reentry court, and I'm constantly hoping to change that language. Chooses not to at this point, or non-compliant, bombed out, or relapsed, setback. Sometimes there's a setback, not necessarily, we don't need to say they're dirty or clean, but they maintain recovery or appropriate in recovery or have a positive or negative drug screen. So that's some of the language is really around the drug screening and the sobriety and versus dirty and clean.
So, again, as Dr. Podesta is mentioning, language matters. Many people who are unfamiliar with substance use disorders do find themselves unintentionally using words that perpetuate these negative stigmas. And as we've been discussing today, these words definitely shape the opinions of others, reinforce these longstanding stereotypes, and have been really found to adversely affect the quality of care, treatment outcomes, even the availability of treatments and the funding of treatments. They may also deter help seeking among those with substance use disorders and their families. That comes from the National Council for Behavioral Health Care. This is another review of the items that Dr. Podesta just mentioned.
Yeah, these are the same. And we have some additions like binge drinking. We should say heavy alcohol use instead. But again, on the left, we didn't say this before. In the middle, opioid replacement or methadone maintenance, we should be saying treatment, medication-assisted treatment or medication, really just bringing it into the medicalized, non-choice oriented language.
All right, Dr. Podesta, you have some additional comments on the description of shame and stigma.
We have just a few minutes, and I want to make sure we have a little time for question and answer. A lot of these things that we talked about, we kind of hit on earlier in the slide deck. Just reminding you that guilt is an action feeling. Shame is a judgment about being something wrong. So shame is being something wrong, and stigma will induce a little bit of guilt, but mostly shame. Low dopamine in the midbrain, which is the reward center, is where shame can set in. If you have low dopamine, you are susceptible to feeling shame, because not everyone that hears you should be ashamed of yourself or what you're doing is bad. Not everyone that hears that feels that, but it's a relationship to the neurochemistry. And those with addiction already have that neurochemistry of that low dopamine. Then on top of that, stigma isolates folks, shame isolates folks. Stigma and shame leads to isolation. Isolation even leads to more low dopamine because you don't have that connection, which can elevate your dopamine and serotonin, your feel-good feelings, and your ability to move forward. Next slide. And then the loneliness we talked already about friends and family. The loneliness can affect friends and family as well. And they might want to be discreet and don't want to seek treatment or embarrassed because of the stigma as well. And so we've talked about the internalizing of negative stigma, and it definitely highly damages people's chance of recovery. So yeah, thank you. That's the slide I wanted to see next. So this is a great presentation. It was actually on abuse of like child abuse and trauma and dissociation, and it also talks about shame and stigma. And so when someone has this, so the beginning of the graph, when someone starts to have this urge of seeking safety, they actually have a high arousal of dissociation. And then time goes on, and then they have low arousal. And that low arousal is the beginning of the isolation and withdrawal and dysphoria. So I just think this is, and when we, if I could superimpose this on the dopamine spike when someone uses a drug, and then the dopamine fall and feeling less than and feeling unmotivated and feeling negative, and then the cycling of that process. So these really are superimposed. Next slide. There's a lot to say about the neurobiology of shame and stigma, and I don't want to go too deep, but basically what we do know is that shame can cause a part of the brain called the median prefrontal cortex, and it can then signal either positive or negative rewards. If it signals the negative rewards, then you get reinforcement, and then the cycle continues. So there's real neurobiological underpinnings of the way that we feel, of the way that stigma affects someone's ability to feel and internalize the shame. And it's for real. It's thought to be related to the circuits that are for hiding from physical danger. If we go way back in time, and our animal colleagues going back to talk about hiding from physical danger to avoid response, or to avoid failing of social belonging. And so those are where the circuitry of ostracism lies. And I think we're seeing some ostracism in the addiction community. Next slide. Okay, so I talked to you about my law clerk. She's 60. She had been avoiding for many years, talking with her 3 children. And so 1 year ago, after like every visit, I would do motivational interviewing and really encourage her to write a letter or talk with her children. And so she went to visit them for Christmas last year, and things were going on that made it so that she actually wasn't able to talk with them, because she felt it would take hours, and it's not a casual conversation, and she thought that they were going to be disappointed in her, and she was so disappointed in herself for having the disease of addiction. Anyway, finally, and this is great, just a couple of weeks ago, she was in my office last time, and she was in my virtual office, I should say, and I kind of just gave her, kind of an ultimatum. I thought that we should just do this now, and not going to fire her if she doesn't do it, but I know how lifted people feel when they can get honest, especially if they're carrying a burden like that for so long. And so I had an extra 45 minutes that day, and I said, can we just include them on a Zoom meeting? And so we did it. And so I was there. So I moderated, and we got one of her children, the one that she was most worried about telling, we got one of her children on, and he was just tearful and would have hugged her and was really proud of her, and really mostly was thankful because he had had a daughter of his own. And so he needed to know what the biology, the possible biology of his new child might be, that they need to make sure that they're very tender and knowledgeable about the possibility of addiction. And so she emailed me just the other day to thank me for that, and that she just feels lifted, like 10,000 pounds have been lifted from her shoulders. And so it began with stigma, and then it internalized to shame, and then a lot of feeling ostracized and fear. And then finally, practically a 15-year process has been overcome.
Well, I appreciate the time that everyone who participated allotted to this topic. And, I tell you, from my perspective, this is a tricky topic because, um, I think a lot of people say, yeah, I know stigma. Everybody knows mental health and substance use is stigma, and they kind of dismiss it. But I hope from today's presentation, you can see through the personal examples and some of the biology, neurobiology that Dr. Podesta shared, and some of the surveys that this stigma has direct real world impact on people, on the healthcare system, on the structure of the system, the funding of the system, people's willingness to treat people, to even be treated by people who are seeing people with substance use disorders. There are real world impacts of this. And perhaps even more importantly, there are specific things you can do using person first, person centered language. Can make a big difference in how people are perceived, how they perceive themselves, and then how others perceive those individuals and provide access to treatment for them. Dr. Podesta, any concluding remarks?
Not about this. I think we really covered everything, and I want everyone to remember the neurobiology is there, and the stigma is real, and internalizing it is really troubling and real for patients. Someone does ask a question that maybe you and I can answer really quickly. What are they supposed to do if a person does not have insurance? This is in regards to referring to a primary care provider. And my take is if someone doesn't have insurance, let's get them insurance that's available for Medicaid expansion. If they fall into the window of making too much money, then oftentimes they're comfortable paying out of pocket. And so you can find somebody that would be able to accept out of pocket money. But FQHCs, federally qualified medical homes, you can go to fqhc.la.gov and find loads of FQHCs, or look at Access Health Louisiana and find primary care providers and all that will be willing and able to take patients. Actually, I can get them in within a day or two if I have reason to contact them. So anything else on that?
Yeah, I think that the other things, we have a safety net system of mental health and substance use providers and providers for those with intellectual disabilities as well in Louisiana, called the local governing entities or human service districts and authorities. So go to one of those and they can help you. They will have services themselves. They have sometimes specialty providers and intensive outpatient and sometimes residential on contract with them. So they provide services not only to those with insurance and with Medicaid, but also to those without. The other thing is our opioid treatment programs, our methadone clinics. They, of course, now are starting to take Medicaid. But we also have, through the Office of Behavioral Health, pushed some grant dollars to both the LGEs and to some other providers, but also opioid treatment or methadone providers to provide and fund free slots, if you will, for individuals. So those, even without insurance, without means to pay, can have access through these additional grant dollars in some of these locations. So that's it. That's all we have time for. Again, Dr. Podesta, thank you very much. It's our second time at bat with this. I thought it went very well. I appreciate your input and your contribution to this. Always good seeing you. Everybody, thanks for joining in.
Thanks, everybody.
Thank you for attending.